Good evening, everyone. Thank you for participating in tonight's webinar titled Performing Bronchoscopy in Times of COVID-19, a review of the International Expert Panel Practice Statement. My name is Jason Cronwall, and I am the Senior Market Manager for Ambu's A-Scope family of single-use bronchoscopes. Tonight's webinar is the second installment of a four-part live educational series covering topics related to bronchoscopy during COVID-19. In this series, experts from various disciplines are sharing their real-world clinical experiences performing bronchoscopy during the pandemic, providing perspectives on the latest society guidelines and statements, and offering suggestions on how to continue performing bronchoscopy while maintaining a safe work environment. Today's webinar will feature Drs. Angela Argento and Elizabeth Malsin from Northwestern University, taking a closer look at the April International Expert Panel Practice Statement on Performing Bronchoscopy in the Times of the COVID-19 Pandemic, published in Respiration, the International Journal of Thoracic Medicine. So this Zoom meeting you're on has a Q&A function, and it's one of the buttons at the bottom of your screen. So please feel free to post your questions at any time throughout the webinar. Some questions we'll take as they come, and others will wait toward the end. Dr. Argento is currently the Director of International Pulmonology at Northwestern University. She is also an Associate Professor at Northwestern. Dr. Argento graduated from St. George's University School of Medicine, did her residency at the University of Medicine Dentistry of New Jersey, did her Pulmonary Critical Care Medicine Fellowship at Yale University, and International Pulmonology Fellowship at Duke University. Dr. Malsin graduated from Drexel University, did her internal medicine residency at University of Pennsylvania. Dr. Malsin completed her fellowship in pulmonary and critical care medicine at Northwestern and is currently in the Interventional Pulmonology Fellowship Program at Northwestern. Dr. Argento and Dr. Malsin, thank you very much for your time this evening. If you don't mind, I'd like to turn the webinar over to you.
Well, thank you so much. Thank you so much for having us. We really appreciate this opportunity to be here and go over this practice statement as well as provide our experience during COVID-19 with bronchoscopy. As far as disclosures are concerned, I do some consulting work for various companies, none of which have any bearing on this talk.
Thank you for inviting both of us to talk. I have no disclosures, but I would be willing to consider anything that anyone has out there to offer me.
Okay.
I'll go to the next slide.
Next slide. So today, as Jason mentioned, we're here to talk about the respiration guidelines published at the end of April of this year, talking about performing bronchoscopy in times of COVID-19 pandemic. And this was a practice statement from an international expert panel, mostly from Europe. It was a really nicely published guideline, and it's interesting how things have changed really quickly. And so we'll go through this practice statement and then again share our own experience and how things have evolved. Next slide.
And so this statement actually starts by talking about bronchoscopy in all comers, so not just patients with coronavirus, but any patient that needs a bronchoscopy for any reasons during the time of the pandemic. And they make recommendations about the staff. So they talk about reducing the number of staff in there in the procedure itself. So no observers, not having extra trainees, medical students, nurses that are training, respiratory therapists that are training, to really minimize the spread of asymptomatic coronavirus carriers. They talk about surgical masking, so masking the patient as much as possible, not just coming into the hospital and sitting in pre-op, but until the procedure is performed. And then as soon as the procedure is finished, putting a mask back on the patient and for the rest of their stay in recovery and in the hospital or in the clinic to keep them masked. They discuss using PPE with correct donning and doffing maneuvers for every patient. Really now is not the time to be lax on our PPE, even in people that we don't think have coronavirus. And finally, they do talk about bronchoscopy being performed with a closed ventilation system. And so using general anesthesia, using intubation, and for things like patients that require rigid bronchoscopy, using traditional ventilation instead of jet ventilation, and really attempting to limit air leak and aerosol generation. With that, we'll go to the next slide.
Okay. And so then they go on to talk about doing bronchoscopy in patients who are known to have COVID-19 or highly suspected to have COVID-19. And this practice statement, as well as basically all of the guidelines surrounding bronchoscopy in the COVID-19 era, really talk about having very clear and specific indications in order to undergo bronchoscopy, just because this is an aerosol generating procedure. And so you want to limit people's exposure to these aerosols. And so what this practice guideline talks about is patients who have a negative nasopharyngeal swab twice, but who have clinical diagnostic uncertainty, meaning they either have imaging and clinical features all associated with COVID-19, but don't have that specific diagnosis. And importantly, they don't have an alternate diagnosis that could also explain these findings. Other things that would warrant a bronchoscopy that this paper discusses is things that would change clinical management. So if they have a concomitant infection that would need to be treated either with antibiotics, antifungals, et cetera, or for therapeutic reasons. So obviously, if a patient has life-threatening airway obstruction, hemoptysis, or foreign body aspiration, then clearly you're going to go and perform a bronchoscopy despite the fact that it's an aerosol generating procedure. Next slide.
The practice statement then gets a little bit more specific about bronchoscopy in coronavirus patients. They note what type of sample you may or may not want to do, and they're very specific that bronchoscopy should really be limited to collecting a BAL, a bronchoalveolar lavage, to avoid taking biopsies in this patient, avoid sampling lymph nodes with TBNA, avoid doing endobronchial biopsies. They talk about how to adequately ventilate the room, and ideally doing this in a negative pressure room. And so traditionally these have been several rooms in the ICU that have been negative pressure. If you're fortunate enough to have an institution that can make a whole floor negative pressure, as we were at Northwestern, that's an appropriate setting. But some bronchoscopy suites are not an appropriate setting. And so maybe considering something like an operating room, if the patient's not in the ICU, would be more appropriate. They go a little bit more specific into their PPE, noting that FFP3, which is a European Union term for a high-grade mask that we would think of as an N95 here in the US or a KN95 in Asia, that filters out and has a good snug fit when you're doing bronchoscopy in known coronavirus patients. And then they again emphasize the need for an experienced bronchoscopist. So this is not the setting for your first year fellow, for your emergency medicine residents, for observers, to really be gaining their initial skills in bronchoscopy, to avoid some of the pitfalls that can happen that would put people at increased risk from performing bronchoscopy in what's already a very high risk population. Next slide.
Okay, and so they have a few tables in this practice guideline that I think are quite well done. So this one talks about bronchoscopy in intubated COVID positive patients, and so again, they're just emphasizing indications and benefits. So primarily, you want to think about using bronchoscopy for secretion management or as a diagnostic tool in case the patient is having radiologic worsening or suspicion of nosocomial infections other than the COVID-19. And so you want to be able to think about concomitant infections in this population. If the patient is having hemoptysis or you're having any difficulty with artificial airways, so whether that's an endotracheal tube, if they were a difficult intubation, if they have tracheostomies in place, you want to be able to look for positioning. You want to be able to clear the secretions out of there, particularly if they're having difficulty ventilating, or if you're just noticing a significant hemoptysis in their suction secretions. You want to think about potential risks, and this can't be emphasized enough. This patient population is extremely high risk for bronchoscopy. So you really want to consider the fact that they may undergo respiratory deterioration as you're performing your bronchoscopy. These patients often require high levels of oxygen, as well as high amounts of PEEP. So their positive end expiratory pressures are significantly elevated in order to recruit their lungs. And so you really want to think that if you're putting a bronchoscope in through an endotracheal tube or a tracheostomy tube, you are going to decrease their ventilation, decrease how much recruitment you're going to have in those lungs. And these patients tend to rapidly deoxygenate and desaturate. And then you get yourself into a trouble because you're going to have a hard time re-recruiting their lungs and getting their oxygenation back to safe levels. And so you really want to think about bronchoscopy and the risks and benefits. So why you're doing the procedure, and are you prepared to handle the risk of oxygen desaturation if you're going to go forward before you do. You also want to think about staff. So despite limiting staff in the room during the time of your bronchoscopy, you also want to think about peri-procedurally, the nurses or respiratory therapists, anybody who's going into that room could be exposed. The aerosols are there for quite some time. And so you want to think about keeping your room empty as much as possible for at least 75 minutes after your procedure in order to try and keep people safe. And whether that's whether that's going to be possible or not is difficult to say. And then as you're in, if you decide to move forward with bronchoscopy, you want to think about your findings. What does the airway mucosa look like? Are there a lot of mucus plugs, thick secretions? Are there blood clots? And how often do you see these things? And then really what you're in there to do is to directly suction. So either perform a directed aspiration to get a diagnosis that's specific to that patient, or you can instill mucoactive agents for secretions to try and thin those secretions and clear the airway to better oxygenate and ventilate these patients. And then again, getting your microbiologic studies is important. Next slide.
And so this table then goes on to really give some practical tips to have a safe, effective, and a brief procedure, right? That's really important. The longer the procedure takes, the more aerosolization. And so they emphasize that to check that all equipment is ready, and they actually give a checklist in this paper that we didn't put because it was going to be too small to see anything on a slide, but they do have a sample checklist because the best time to realize you don't have all the equipment is before you've gone in the room. And that pre-procedure period, going over things, getting used to how you're planning to take your steps is key. Making sure that you're on the appropriate settings on your support devices, that the ventilator is set to 100% FiO2, that you're satisfied if the patient's on ECMO, that their flow and their sweep are optimized. And if you think that they may have a decompensation, that you can increase those things ahead of time so that you're not delaying when you've already opened a circuit and are doing a bronchoscopy to manage an ECMO circuit. They give the tip of using a neuromuscular blocker unless contraindicated, and that's certainly something that we'll talk about and that we used regularly to prevent the patient from moving and more importantly, prevent the patient from coughing at all. To have a staff check of PPE, to have someone watch you don and doff. This is the time that you want that to be perfect, and it's a time when somebody else should take a look and make sure that when you've walked in the room, you're increasing the FiO2 to 100%, to make sure that every single box is checked and not just checked by one person, but checked by several people. And then to pre-prepare the bronchoscope and the sampler, whether you're using a disposable scope like the Ambu scope, whether you're using the broncho sampler, whether you're using a Lucan's trap, but to have that all kind of connected. So connecting, in the Ambu scope's case, the broncho sampler to the scope, and then connecting the scope to the view monitor. Being ready to put your bronchoscope and your adapter into the patient before you're thinking about even breaking the circuit. Prior to breaking the circuit, making sure you have a plan to stop ventilation when you break the circuit so that air is not moving in and out of the patient or in and out of the ventilator tubing that we know has been in contact with deep respiratory sample already. So clamping the tube, performing an inspiratory hold on the ventilator as the circuit breaks, knowing how to use a broncho sampler, knowing how you're going to collect your sample, knowing that if you're using something like a Lucan's trap, that it shouldn't be floating in the air and that you're going to lose your sample. And then knowing that at completion, you're not just going to quick pull out the bronchoscope without reversing these steps, clamping the endotracheal tube, making sure that you stop ventilation, and then only then taking out your bronchoscope, taking out your adapter, and undoing the clamp and resuming ventilation. Next slide.
Okay. So again, this is a bit of a reiteration of their table, but really bronchoscopy in COVID-19 patients in the ICU, really they emphasize using directed samplings by BAL to rule out concomitant infections. You would use it also if the patient had lobar collapse, specifically from mucus plugging, and also to verify ET tube placement. We did that a lot. And I think that's changed over the course of time. Again, trying to limit PPE usage, trying to limit staff that goes into the room in general, whether that's with bronchoscopy or not. I think chest x-rays were limited a lot kind of as we progress through the pandemic, just to try and again keep the radiology techs out of the rooms and prevent exposures, prevent PPE usage, etc. Again, they recommend the use of the checklist, and we developed our own. The one in the paper is quite good. You want to think about pre-procedure things during the procedure and then post-procedure as part of your checklist. And we developed ours really based on our local trends and needs and our workflows. And I would highly recommend that all of you do the same. You really want to think about using general anesthesia and muscle relaxants, again, to just keep the patient stable and minimize aerosol generation. Disposable equipment, I think, is key. So we use the Ambu scopes. There are other disposable scopes on the market, but I would really recommend disposable equipment when available. It just helps to keep everything contained. So other institutions are using their regular reusable bronchoscopes, but that then requires that these scopes have to be packaged, transported, and processed, exposing other people along the way. So really disposable equipment, I think, is key. And then, something that I think is also really important is just, again, these patients are pretty fragile on a lot of sedation, oxygen, et cetera. And so coming up with an emergency plan is really important. You have to be able to perform emergency protocols on these patients, and you have to be donned and doffed, et cetera. So you have to have a plan for how you're going to do that if these patients go south during your procedure or peri-procedure. And so that's something I think really important. And it's going to be, again, something local that you're going to have to develop that would go along with your workflows. And then again, the simple things like putting your FiO2 up to 100%, monitoring your oxygenation during the procedure. If they're on ECMO, trying to hold anticoagulation and monitor their coagulation parameters, keeping your platelets above 50 if possible. And again, processing your specimens according to your institutional guidelines. So for us, that meant double bagging the specimen, but you would put the specimen, use the container, put it into a bag, you would chlorhexidine the bag, and then you would pass it to go into a second bag with the nurses out front. And we'll talk about that a little bit later. Next slide.
And so finally, the statement does give some recommendations about what to think about post-bronchoscopy. And I can't emphasize enough, the time to think about what's going to happen post-bronchoscopy is before you've started the bronchoscopy. But the post-bronch necessities that they list include monitoring someone's FiO2. You're going to go into the procedure, put them on 100% FiO2. From anywhere from 21% all the way that they started there. But they may end up somewhere in the middle. And it's important to think about if the nurse or the respiratory therapist is going to, if you put them back on 40%, but they need a little bit more, the nurse or the respiratory therapist is going to have to come into the room and change that after you've just done an aerosol generating procedure. To think about how much PEEP they were on. Are they going to need a little bit of a recruitment maneuver? What's their body habitus? Are they somebody that you would expect to de-recruit? They share, the practice statement does say that a chest x-ray to exclude pneumothorax is necessary. And you should certainly think about pneumothorax should this patient decompensate at some point post-procedure, including to the point where does this person need an emergent ultrasound before I've even left the room from the bronch? Do they need a needle decompression? Are they high enough risk that I should have a chest tube available to put in them? They talk again about post-bronch necessity of using disposable equipment as able. And so taking as little out from the room when you're done is ideal. So in our case, just being able to wipe down the Ambu scope tower that we use and the monitor, push that out of the room. I'm ready to doff and get out of the room safely. And then finally, if you are using non-disposable scopes, how you're going to be processing those scopes, because your institutional guidelines like ours may have changed, and how those scopes are handled, where they go, how they're labeled is going to be very different than those that we're regularly using in the ICU or elsewhere for non-COVID procedures. And everyone's going to want to know that. Your people down, if you're using a scope that's from the operating room, those people deserve to know that scope's been used in COVID-19 patient, and that it's kept separate from anything else that they're cleaning, to really be a good team player and help your workflows. And so with that, we'll go to the next slide.
Okay, so now we really wanted to, that kind of summarizes the practice statement. And now we really wanted to share our own experience at Northwestern. Next slide. And so really we performed a lot of bronchoscopy. So we performed more than 400 in known COVID positive patients in the ICUs at Northwestern. And again, our common reasons for bronchoscopy were all the same things that were identified in this guideline. So primarily it was to identify co-infections or to confirm the diagnosis of COVID-19 at the time of intubation. So if it was highly suspected despite negative nasopharyngeal swabs, we would always send a COVID BAL sample down to the lab if COVID-19 was suspected. I think that our patients did really well despite being intubated in the ICU. We had a mortality rate of about 15%, which was really great. And I think a lot of that had to do with the fact that we did significant airway clearance using bronchoscopy. And so we had improved secretion burdens, and we just cleared a lot of those really thick, almost airway cast secretions in several patients. And that was really great when we weren't sure, could you use nebulizers? Could you use airway clearance techniques like vest therapies, et cetera? And then, certainly if they had hemoptysis, we would perform bronchoscopy and during tracheostomy placement. Next slide.
And so we're going to talk a little bit about our actual specific protocol, which is, an adaptation of what they used in this statement. And so we'll go through it in somewhat of the same fashion. So our pre-procedure kind of thought process was to talk about minimizing people in the room. So we actually were doing these with 1 to 2 people in the room. When I started, I was the first ICU attending to attend just in the COVID ICU. And I was activated when we put our first patient on ECMO. So she was going to need a bronchoscopy. At that time, we didn't know what to expect. We didn't know what the infections rates were going to be for healthcare workers. We were seeing what was going on in New York. And so we did not have trainees doing bronchoscopy at that time. So it was just me, myself, the bedside nurse in the ICU, and the respiratory therapist would have a little huddle outside and talk about a timeout, making sure we had everything we needed. The nurse would then go in and give a dose of Nimbex, usually cisatracurium, as a neuromuscular blocker. And then she would leave and I would go in. I would bring the necessary equipment and then have usually both, especially at the start before we kind of got our workflows perfectly established, have both the RN and the RT available outside for anything that we would need on call, and have them ready to come into the room, only in the case of an emergency if I needed help. In the setting of this, we used enhanced PPE. Dr. Argento and I are very fortunate to work at a great institution like Northwestern, where we haven't had a true access problem to any PPE. But this is the time when we weren't required to be wearing PAPRs in any of our patients without during bronchoscopy, but this is the time to be wearing a gown, to have it tied right, to have a cap on my hair, to make sure my N95 is fit well, to make sure I have everything that I need. Make sure that I have eye protection, and we were using, for the most part, goggles, not just face shields, but true goggles. We really maximized disposables, as I think I mentioned before, the things that were coming in. So I brought in a bag of supplies along with the Ambu tower and the Ambu scope. The only thing that left with me was the tower with the iPad on it for visualization. Everything else was able to be thrown away in the room. As soon as I went in the room, I'd put the oxygen up to 100%. I would set up my bronchoscope and put on our collection trap. I would clamp the tube, and then actually the statement talks about doing an inspiratory hold. We found that to be a little bit more challenging. And so what we would do is actually pull the inspiratory limb of the ventilator, and that picture that you see there, that square part is actually the inspiratory limb. I don't know if you can see Dr. Argento is highlighting it for us. So I would clamp the tube and disconnect that, insert the Ambu scope with the adapter on, reinsert the inspiratory limb, and then unclamp the tube. And then be ready to do the bronchoscopy. So we'll go on to the next slide.
Okay, so during the procedure, we are accustomed to and always did, despite COVID-19, perform a full airway inspection. So we did go bilaterally, so right and left, and then we would perform the BAL. If it needed to be directed, it could be directed, but if there was just diffuse infiltrates on the imaging, then we would either perform the BAL in the lingula or the right middle lobe, as those gave us the best return for our BALs. We would routinely instill 120 cc's of saline for lavage, again, to just maximize your yield and make sure that you were getting an adequate sample. And then, we would remove the scope. So this was really a quick procedure, typically a minute or at the most. I feel like that was as much as it went. So the scope removed in a minute or so if this was just a straightforward BAL. If you had to clear out some secretions, it might be a few minutes more, but these were never long procedures. So very quick. So then you would withdraw the scope back into the ET tube. You'd clamp your ET tube. We disconnected our inspiratory limb, but again, you could do an inspiratory pause. And then the scope and adapter were removed, and you would reconnect the ventilator and unclamp your ET tube so that ventilation would be restored. Next slide.
And so once we were able to restore the circuit, we're ready to follow our protocol for breakdown. And post-procedure included specimen processing. So our specimen processing, for example, at Northwestern, and again, having this, knowing what your specimen processing is going to be is key before you go into the room. And so the first few bronchoscopies I did going into the room, I think the nurse probably thought I was crazy. I'm like, okay, so I'm going to hand this out to you. And we went over it kind of quite a few times. And like, I want you to make sure that I've wiped down the bag. So our BAL would go into a biohazard bag. I then wiped it with chlorhexidine wipes, opened the door, and then without touching the outside of a bag, it was placed into a second bag outside the room. In the initial parts of our COVID epidemic here in Chicago, everything that came from a COVID patient had to be hand delivered to the lab. They weren't going through the tube system. I then would wipe down our scope tower while still in the room and then push it out of the room. I would make sure I had thrown everything away, and I would make sure that the patient was doing okay. And so making sure that the oxygen still looks okay, making sure that you've come down on the oxygen. If they were on 40% during the procedure, you come down to 40% from your 100% that you were on during the procedure, and make sure their saturation's still okay. If it's not, while I'm still in the room, I would figure out what they needed. If they needed a recruitment maneuver, I could do that in the room. And so avoiding having to have another provider urgently go into the room where, they're going to have to don PPE faster, and that's where mistakes are made, and that's how more people are exposed. And so only after that would I, perform appropriate doffing. And finally, one of the other things that I think we didn't do that the statement kind of emphasizes is follow-up chest x-rays. So just like I don't want my RT or my RN to go into the room, I don't want a RAIDS tech to go into the room during the procedure. And so we really only did follow-up chest x-rays if there was a clinical change post the procedure. And so if they were having higher peak pressures, if they were desaturating more than you expected, if they were hemodynamically unstable, and there was a high suspicion for a pneumothorax. But the other thing that, we found ourselves doing, and pneumothorax happens in these patients a lot, as it does in patients with severe ARDS, both peribronchoscopy and not, is knowing where your ultrasound is, knowing where the stuff for a chest tube is, and being comfortable having a plan for what to do if you have a high suspicion for a pneumothorax, and having people available that can identify that for you, not just with a chest x-ray, but with an ultrasound, and act on that rather quickly. And all of that is to discourage staff from really having to enter the room for 75 minutes post-bronchoscopy. We really had that as one of our goals. And finally, a couple things that we did here at Northwestern to make sure that that happened is that our vents could be managed remotely, and that I was able to optimize meds. And so having the nurse be able to manage the meds with me at the bedside before I left the room. Next slide.
Great. And so what we found, we're actually in the process, we've written up some of our results from this interesting time, as many other institutions are as well. And so just to share with you some of our articles that are in press is that healthcare workers, at least at Northwestern, who did have exposure to bronchoscopy, did not become COVID positive when we tested them either by nasopharyngeal swab or by serologies. And so I think that's really important. Once we kind of started seeing that more people felt comfortable performing the bronchoscopies, I think initially there was a handful of ICU attendings, as well as the interventional pulmonary service that was comfortable, and that kind of increased over time as we showed that proper donning and doffing of PPE, being careful, trying to limit people in the room, and being specific about the procedure and following a protocol gave people the confidence. And so now there were more, several more attendings that then participated in bronchoscopy at our institution. We also found that concomitant infections are extremely common in COVID-19 patients, much more than we would have expected. So in our cohort of patients, it was about 30%. So I think for us, bronchoscopy was actually extremely helpful and did help us to achieve this really low mortality rate that we found in our population. So again, concomitant infections and VAPs, quite common. And so we found, again, our mortality rate was somewhere between 10 and 15%. So particularly low compared to other places that have reported their mortality rates. And we found that there was mucus plugging was a very common occurrence in COVID-19 pneumonia. And the pulmonary toileting was really critical to maintain safe ventilator parameters. So that was really helpful. All right. And with that, I think that's our last slide. If you want to go to the next slide, it just says thank you. If anybody has any questions, we're happy to stay on and answer.
So looking at the question was posed early on, I think you went through and described how the practice statement differed from what you did at Northwestern. But I do have two questions for you. The first one is, what did you do perk trachs bedside during the pandemic, at least the surge?
Yeah. So really the interventional pulmonary team did the vast majority of the percutaneous tracheostomies during the pandemic. And thoracic surgery also did some. And we developed a very specific protocol as well that sort of included the same ventilator management. So kind of clamping the endotracheal tube, discontinuing the inspiratory limb, those kinds of things. We did most of our perc trachs pretty much apneic. We're pretty quick with our percutaneous tracheostomies. And so for the most part, they can be done apneic. The other thing that I think was instrumental in our perc trach protocol was that we packed the mouth and nose, again, to kind of minimize aerosol generation. And so I think that was pretty interesting. Unlike the NYU protocol where they sort of side saddle the bronchoscope to an endotracheal tube, we weren't able to make that one work. I don't know. It was very difficult, or at least we found it very difficult to visualize our landmarks that are really key when you're doing a perc trach. If you had an endotracheal tube and a bronchoscope and then getting a needle into the airway, et cetera, there just didn't seem to be enough real estate or room for us to really make sure we were where we wanted to be. And so we found that it was taking us longer to try and perform that version or that protocol. And so we sort of stuck with what we knew and just made small adjustments to our typical perk-trach protocol, like I said, with the ventilator management, and trying to keep the patient apneic if they were able to be. And if not, then obviously we would ventilate them through the procedure.
Okay. Let's see, another question came up. For what percentage of your COVID patients did you perform a BAL and collect their samples to be sent to the lab?
I think that number, I don't have the exact number, but I think it's over 90%. I can tell you that several of these patients underwent a bronchoscopy several times through their kind of prolonged hospitalization. And so, our total number of 400 is way more than the number of intubated coronavirus patients we've treated, fortunately, here at Northwestern.
Okay.
But our usual practice was when they were intubated, we went into the room to verify ET tube position bronchoscopically and got a sample at the same time. And a lot of these patients, especially during the beginning when we didn't know kind of how much airway clearance we could offer these folks in terms of hypertonic saline, and we weren't using vest therapy, we were bronching people for pulmonary toilet to clear casts. And so the majority of our patients had a sample sent at some point during their hospitalization. Most of the time they had one within 24 hours of intubation or in those that were transferred on arrival. And the results, we haven't fully shared it, but are surprising how many people had co-infections and how many people had co-infections within days of intubation of resistant organisms even. So things that weren't necessarily going to be covered by kind of Banksocin, or if it was at intubation of Levaquin or ceftriaxone or Zithro, we would get frequent patients even from outside hospitals who couldn't get into an ICU there, were at an ER, and you do a BAL and they're growing an ESBL, Klebsiella, or Pseudomonas, that you're really thinking of going straight to a pretty hardcore antibiotic.
Yeah.
Interesting. Another question. So you mentioned a straightforward BAL was completed in about a minute. How much quicker is that than prior to the pandemic?
Depends. Some of it is that we were using pretty experienced operators. We have a big training program here. We have 15 general pulmonary fellows. And so prior to the pandemic, they were the ones performing most of the bronchoscopies for us with an attending supervision. I think probably we think that everyone should be able to perform a quick airway inspection and a BAL in less than 5 minutes. And so I think we cut that pretty significantly. On our fellows, once we got the okay to bronch, became very, very proficient in these procedures on those that elected to do them with us.
Let's see, there's one more question. Have your bronch procedure volumes decreased since COVID?
I would say no. A BAL in the ICU, those have decreased since COVID has sort of come down more recently. But our other business, I guess in interventional pulmonary, we do a lot of bronchoscopy, and a lot of our cancer patients were on hold during the pandemic. And so our business has pretty much stayed solid and pretty steadily high as far as bronchoscopy is concerned. There's still a lot of interesting things about, do you test for COVID before? Are you wearing your N95 masks for all bronchoscopy? Those are the kind of things we're still doing here. And I think that varies from institution to institution.
Okay. Another question. How did the lab P&P change for running samples?
So for us, initially, anything COVID related had to come hand delivered to the lab, and there was a specific place that you had to give it, and it had to be kind of labeled and identified as a COVID sample. And then I don't know what happened to it once it got to the lab.
I'm actually, as kind of the first person to come in, knew a little bit more about that, because things were not, we're a robust place. They handle a lot of samples for us, and things were just not coming back quickly. And so they had been using a separate flow cytometer. So you weren't getting your differentials quickly. Certainly things have changed. I know even in the previous webinar, they mentioned how things have changed over time, and we were only being able to run on lower respiratory samples, things twice a day. Usually our results would come back rather quickly. And so we were only running that twice a day. So you would get coronavirus testing from BALs at 11 o'clock and 3 o'clock. And if you missed that cutoff late in the day, you wouldn't know in some of these negative nasopharyngeal people until the next day. And do you treat them as coronavirus? Do you not treat them as coronavirus? And all of that's changed. We now have very rapid turnaround of things. We now have differentials back. In the middle of all of this, we had a lower respiratory nucleic acid test that also went live. We have a big pneumonia research group here. And that was really helpful to have and to really diagnose some of these VAPs and to identify these resistance genes has just been, it was a great time for that to go live.
It was really helpful. Yeah.
Another question, outside of the COVID unit, have your bronch procedures changed?
They have. Unfortunately, I think like everywhere else, everyone gets COVID swabbed within 72 hours. And then we decide, does the patient, do we treat them as COVID negative, which is not terribly different from COVID positive. So everybody gets an N95 mask, eye protection, headgear, so something to cover your hair and your head. You have to wear full PPE, so full gown, shoe covers, etc. For the most part, whether they are COVID positive or negative. And so it really has changed our bronchoscopy procedure in general. So it does definitely slow things down, but I think, it helps. I think none of us have gotten sick from doing bronchoscopy during this time, and that's been really great. And I think it's given our staff a lot of confidence that it's okay. I think they were really scared at the beginning, especially to perform things, that weren't COVID related. They were like, oh gosh, should we really be doing this? And so it's been interesting to see the change, but now people seem to be comfortable. It just takes longer.
We're starting to see some of these coronavirus survivors now come back and need procedures that they have persistent abnormalities, that they have a pleural effusion, and how to manage these patients when they're now walkie-talkie feeling relatively well out in the community, come in and need a procedure, and how do you manage that, and where do they go? What's the testing? How to get those people in and out is something that we're developing a workflow for.
Oh, we forgot. We're also bronching some patients because they come back with tracheal stenosis after their tracheostomies. And even in patients who were just intubated for COVID, maybe even without tracheostomy, they're coming in with some tracheal stenosis. We've also got a paper coming out on that. So we forgot.
Interesting. Something to look forward to. Kind of the last question is really more about, as you look at what Northwestern implemented through the surge and as things have quieted down, is there anything that you're planning to do differently in case a surge does come in the fall?
Mm-hmm. Do you want to take that one, or you want me to?
I think things that we would do differently. I think we were on the scale of things, we were in a very aggressive institution in terms of bronchoscopy. I think that we would continue to be kind of as aggressive, if not more aggressive. We've really learned a lot about how these patients tend to act. I think for me, one of the things that was highlighted is the thick secretions and pulmonary toilet bronchs that I was doing. I'm early in my interventional pulmonary training, and so I was bronching people that as an attending, I would have been more uncomfortable bronching. But it was surprising how much data the bronch led to that was actually helpful, and how well the patients actually tolerated it if you followed the protocol, if you were brief. We really didn't have anyone decompensate to the point where I said, I really wish I hadn't done this bronchoscopy. And there were so many times that I said this was actually exquisitely helpful to either clinically clear secretions or to help make a diagnosis of a ventilator-associated or a concomitant infection. That I would encourage myself and my colleagues to be as aggressive and to kind of keep up the hard work of doing the physical labor of bronching these people, because it's a sweaty job.
Yeah, I think the key is also just to be prepared. So the idea of like having a checklist, developing protocols that work for the workflows of your institution are really important. And you have to have things in place. So you have to have the personnel, the PPE. You have to have the backup in place. So your nurses have to be ready, willing, and able to come in should you require their help. And we were fortunate that we did a lot of planning ahead of time. We thought a lot about our procedures and our protocols, and we didn't require a lot of those things. But, when they happen, and you want to be prepared for that stuff. So I think we were just really lucky. I think our team here at Northwestern was really good about really planning this stuff out, from space to resource allocation and all of that stuff. So we were very lucky.
Yeah. I think it's hard sometimes with these statements to take the idea of what really is a clinical indication. It's something black and white on this statement, this piece of paper, but it's not that black and white in real life. It's some sort of gray. Should I bronch this person? Is this really a clinical indication? I know they had an infection, but we've been treating them with X, Y, and Z antibiotic. And I think I would err more on the side of going out and doing the bronchoscopy and saying, if you think that they need a bronchoscopy, if this is a patient that you would have done a bronchoscopy in if they were on 10% less oxygen, or if you knew they didn't have coronavirus, you should probably do the bronchoscopy. You probably should get a sample, or you should clear them out.
Yeah, I think kind of keeping in mind your critical care that you've always done. So in your patients with ARDS, would you have bronched them? If so, then you should probably bronch this patient, even though they have coronavirus. So those kinds of things are important to keep in mind.
In our non-coronavirus patients, we use mini BALs or non-bronch BALs, and that's not available for coronavirus patients in our institution. We don't have the resources to support it and the RTs to support doing it in all these patients. And so if it's a patient you would have done that in, had they not had coronavirus, I would go and get the sample bronchoscopically.
Yeah.
Okay. Good. Well, thank you to Dr. Angelo and Dr. Malsin. Thank you very much for your time this evening. So some really good insights, and appreciate you sharing your thoughts on the statement and how it applies in what you're doing there at Northwestern University. So thank you very much.
Thank you so much for having me.
Thank you for having us. We really appreciate it.
And for those of you in the webinar, I just wanted to make sure that you're aware of 2 upcoming webinars that rounds out the 4 webinar educational series. So next week we have a webinar that looks at reducing the risk to patient and healthcare provider during bronchoscopy. And then the final webinar at the end of this month looks at the health economics of reusable versus single-use technology. Thank you all online for taking time to attend this webinar. It will be available for replay online next week. This concludes the webinar, and I wish everyone a pleasant evening.